classification. So this is something that I used in the past, so I'm just giving it to you to work on. Are you in Monday's lab, Letitia? Are you in Monday's lab? Yes, take one.
That's fine.
And your
I know.
partners will
I
tell you
finally
what
had
to
to,
change.
because I was like, oh no, getting a little out of control.
Thank you.
Danielle, I helped you yesterday, right?
Oh, yeah.
Okay.
Yeah.
Okay. I'm like,
I feel like you're definitely like two different things in one.
Identifying the
did I? Okay.
Okay, as long as you kind of understood after.
These are medical abbreviations. I didn't give the abbreviations. You figure them out. But a lot of these terms I don't write out. I use the medical abbreviation even on my exams. So the more familiar you are with medical abbreviations, you can get through what I'm asking you, okay? All right. So once you go through it, a lot of them are right there in your in the front cover of Egan's. Some of them you may be familiar with if you are employed in a healthcare facility, and some you may be familiar with just because you know what they are. Become familiar. Again, this list by no means is exhaustive.
You gave us that yellow handout too about abbreviations.
Yeah, learn them. Learn them. Warn. Well, learn them. You may happen to see them on your final. All I can say. Ebony, are you in Monday's lab?
Yes, ma'am.
I'd like to see you, please. This is a handout which I was going to give, but Ms. Pope said some of you all were, so there it is.
Thank you.
Okay, so you should have two handouts for me. Commonly used medical abbreviations in respiratory care, actually in pharmacology too. Then pharmacology classifications, trade, and generic names. Start working on these and know how to classify these drugs. Okay, it's more important that you know how to classify a drug and when it's appropriately used as opposed to a dosage. Okay, the first thing that I want to clarify, because I've had several people ask me, that looks just like Ms. Pope, doesn't it? I knew she didn't even have to put her name. I want to clarify, give it to you in a different way. When you talk about a compensated blood gases, and I'm not going to use numbers, I'm just going to use arrows, okay, or N for normal. When you talk about an acute blood gas, let's say respiratory acidosis, I'm not going to be on this long. I just want to clarify and make it a point here. Your pH is decreased because it's acid, right? Your PaCO2 is increased because it's acid, yes?
Yes.
And the bicarb is normal, yes?
Yes.
So in order for compensation to occur, if this is the primary problem, which is respiratory, that means the kidneys have to kick in. And if this is acidosis, the kidneys have to become alkalosis, right? So the compensatory mechanism or the compensatory response to respiratory acidosis, if you will, I'll put it back on the board. The pH, this is compensated. pH is now normal, yes?
Yes.
That's how we know. What's the definition of a blood gas being compensated? pH is normal, chronic normal, right? All right. This is still the primary problem, respiratory acidosis, right?
Right.
All right. But now what has happened, the bicarb kicks in and becomes alkalotic. And as the bicarb kicks in and becomes alkalotic, it raises that pH and it raises it to normal. Okay? So the compensatory factor for respiratory acidosis is metabolic. The primary problem is lungs, so the kidneys kick in. See that? So this is acidosis. This has to become alkalosis. Everybody see that? That's how we know this is a compensated blood gas. So let's do another one. Primary problem, I'll say, is metabolic acidosis. So the pH is decreased, yes? The PaCO2 is what? Normal. And the bicarb is decreased. That's acid, right? So the primary problem is metabolic acidosis. Everybody agree?
Mm-hmm.
All right. Now this is compensated metabolic alkalosis. pH is normal. Yes? Bicarb is still decreased because that's the primary problem. But now for compensation to occur, what has to happen? The lungs have to kick in. And if this is metabolic acidosis, then the lungs have to portray or demonstrate respiratory alkalosis. So the primary problem is metabolic acidosis, and the compensatory factor or mechanism, whatever you want to call it, is respiratory alkalosis. Alkalosis. Okay, so we got an acid pH. When this PCO2 drops and the patient hyperventilates, what does it do? It raises the pH to normal. Can you all see this without numbers?
Yeah.
Just a few of you are speaking.
Yes.
Oh, yeah.
Yes.
Okay. All right. So without another blood gas, if the primary problem is metabolic alkalosis, write it down. Just write down metabolic alkalosis. If the primary problem is metabolic alkalosis, what's the compensatory factor? Respiratory acidosis. Very good. It has to happen. So they're opposite. Remember I told you one has to be base, one has to be acid. It doesn't matter which one is which. But they have to be opposite in order for the pH to be normal. Right? All right. And then we can determine what the primary problem was based on the status of the pH. Everybody got that?
Yes, ma'am.
So let's go through it again. I don't know, some people missed that and they were perplexed. I don't know what number that was on the quiz
Right.
about if compensation occurs. If the primary problem back to here is respiratory acidosis, for it to be corrected, the PCO2 is not going to go down. That's the problem. Something else has to correct it. So the bicarb kicks in. It may take 72 hours, as I told you. The bicarb will kick in and become opposite. So if this is respiratory acidosis, then it becomes metabolic alkalosis. And as it goes up, what does when hydrogen ions go up? When hydrogen ions go down. Let's look at even like this goes up. This does what? Goes down, and therefore it raises the pH. And it raised the pH from 7, whatever it was, to normal. This is what happens. And this is what makes it compensate. So if your primary problem is metabolic acidosis, what's the compensatory factor?
Respiratory alkalosis.
And you know respiratory alkalosis as a patient hyperventilating. So if I ask you if you have metabolic alkalosis, metabolic alkalosis. Which of the following is a compensatory factor? You know the focus is metabolic alkalosis, so the compensatory factor is respiratory acidosis. But you also know that as hypoventilation. Any way it comes to you, you need to be able to decipher and get through it. That's how you know you understand blood gases. It's just not about numbers. Okay? Any questions with this? So let's go through it one more time. If the primary problem is respiratory acidosis, what's compensating?
Metabolic.
Good. If the primary problem is metabolic acidosis, what's compensating?
Respiratory acidosis.
Huh?
Did you say acidosis or
Metabolic acidosis.
Acidosis.
Breathing easy. Okay. Now, if the primary problem is metabolic alkalosis, what's compensating?
Respiratory acidosis.
Okay. And if the primary problem is respiratory alkalosis, what's compensating? You all got it?
Yes.
And so if you have that compensatory factor, that will normalize the pH. Got it?
Yes.
All right. Does that help you?
Yes.
All right. I'm done with blood gases today. So if you go back, I don't know what number that was, but I think it was on the second page. It was the last number, number 15, I believe it was. For those that didn't get that correct, if you go back and look at it, it should make sense to you now. Anytime a blood gas is compensated, or if someone or the question is asking you what has to happen for compensation to occur, you need to look somewhere for pH to be normal. Yes? And then based on the primary problem, you want to see the opposite condition. So if the primary problem is respiratory, then we're going to go look at the kidneys. If the primary problem is kidneys, then we're going to go to the lungs. And if one is acid, then the other must become base. If the primary problem is base, then the other must become acid. Okay? And what's happening is literally acid or base is controlling that hydrogen ion. That's what's going on here. When bicarb goes up, by the definition of an alkalosis, hydrogen ions are given off. And when hydrogen ions are given off, it raises the pH. And so this is what corrects respiratory acidosis. Any questions? Yes.
So that's in a compensated situation. What about the uncompensated or the partially?
The pH is not.
So the pH, okay.
If it's partially compensated, you have this. pH is still out of range. But if you have, I'll use this. This was the question. You still have respiratory acidosis. And I have metabolic alkalosis. But I know it's partially compensated because my pH is not within normal range.
Okay.
That's how I know it's partially compensated. So the difference between partially compensated and compensated is the pH.
Okay.
If the pH is within normal range, that blood gas is compensated. If the pH is not within normal range and you have both conditions, it's partially compensated.
Okay.
And then if it's uncompensated, you won't have both these conditions. If this was uncompensated respiratory acidosis, this would be normal.
Normal. Okay.
Because it hasn't attempted to kick in and compensate.
Okay.
Got it? Any questions? If you don't, you let me know. Because I'm ready to move on. It's more, I got to talk about causes of metabolic problems. Does that help you?
Yes.
Have any of you gone to the website, that link that I gave you, the ABG tutor?
I did, but it looked like you needed to purchase it.
Really?
Mhm.
Oh, I didn't know that.
Yeah.
It used to be free.
Yeah,
I
it's
need
not.
to go check.
Yeah,
Okay,
it's
I'll
not.
go back and check and see then if I can find a free website. Because before you could go in there and do as many blood gases as you
Yeah, it
want.
doesn't. It says you can do
Stop
it online, you can do it to just pay for it, so you download something or you buy it through the mail. So either way, you gotta purchase it.
Thank you.
YouTube's got some ABG videos that are pretty helpful. I thought.
YouTube does?
Yeah.
Okay. Well, if you guys give me the link or whatever, I can do it, or you can just go to YouTube. But what my point is, I know the college emphasizes the use, excuse me, don't you know, the college emphasizes the use of technology, but I don't want you to use technology now, because if you go out and read certain information, it will confuse you. And some of you have told me, I went to this website, now you're confused. I told you not to do it. Just learn what I'm giving you and you'll be okay. Okay? Then once you get the fundamentals, then you can expand your knowledge however you like. And I'll be happy to learn from you. Okay? But learn blood gases like this. And the reason I don't use the text is because the text is not teaching you step by step. I'm teaching you step by step. Okay? It's not difficult. Perhaps you can go back and read the text now and get some understanding, but the text includes some pathophysiology, and we haven't gone through pathophysiology. Okay, so if you just work with me, stay with me, understand this, you're doing good. All right? Don't want more and more and more, and then you can't navigate through what I gave you. You can navigate through what I gave you, then I know we're ready to go to the next step. And so hopefully, by no one having any questions, I know we're ready to go to the next step. But I want you to work on this. I gave you a sheet. I don't know what color it is. I don't know if it's white, yellow, gold, whatever. It has about 20 blood gases on it, plus I gave you the answers. Start going through that. That's numbers. But to understand blood gases, you really don't need numbers. So when I give you a question, if the pH is decreased, what's the activity of the hydrogen ion? You should be able to tell me that and not get it wrong. Or if I ask you, what's the compensatory factor for respiratory acidosis, you should be able to write out metabolic alkalosis. Right? Any way it comes. Yes, in the clinical environment, you're truly going to have numbers. You are. But the reason I'm going through this is because you may need to explain why those numbers are like they are. And you can't tell anyone, well, it just is. You got to be able to understand it to get through, to help someone else get through. Okay? All right, so work on those blood gas interpretations. And your quiz on Monday, I sent an email yesterday, your quiz on Monday will not have any blood gas values on it. I'm asking you specific questions, and it is not multiple choice. It is not. And this way, you'll know and I know. Okay? Some people have gotten perfect scores since day one on blood gases. Accolades to you. I know you understand it. But some people are struggling. I don't know where your struggle is, and I'm not going to keep begging. But you got to get this. Because if you don't get this, you'll never get through pathophysiology. You will never get through mechanical ventilation. You must understand blood gases to get through mechanical ventilation because the changes we make are based on blood gases. Make sense? So keep trucking at it, keep trucking at it. So even when I don't give you homework, you should have homework. Work on these blood gases, okay? And respiratory therapists look at things not one-dimensional, but we look at things two-dimensional, three-dimensional. We can go in the front door, we can go in the back door, we can go in the side door, we can get on the roof and look down and call what it is. And that's what we're doing, all right? It's just not one-dimensional. Okay, I'm moving on. I talked to Miss Pope yesterday evening. I caught her. And we were talking about the progression of the classes. So she has graciously agreed, and I just love her. In lab, what she's going to do is take you through the process of setting up an MDI, a DPI, and even a small volume nebulizer. And you guys will practice with each other how to administer that therapy. And that's going to be part of your competencies. And I was like, cool beans. So I really don't have to go through chapter 3 now because we're going to go through the drugs, but she's going to go through the setup. She said she'll start Monday. So all I want to tell you, you have the PowerPoint for chapter 3. All I wanted to, and I went through it Tuesday. When we administer our drugs, it's either administered via small volume nebulizer, an MDI, or DPI. Okay. What you're going to have to know, what drugs do we actually administer MDI, what drugs come in SVN, and what drugs come in DPI. And that's chapter 3. But you do have the PowerPoint. Okay? And then what I can tell you, I had mentioned before, the biggest problem with our aerosol drug, or problem or disadvantages, is when patients cannot follow instructions. And I'm not talking about patients who just are not being cooperative. I'm just talking about they just can't coordinate it. You know what I'm saying? It's like rubbing your belly and patting your head together. Some people can't do that, right? And so if they have poor coordination, sometimes MDIs and DPIs and SVNs are ineffective. So it's very, very important that we instruct our patients and demonstrate. And it doesn't matter if a patient has a language barrier. You have to become animated and teach them. You have to interact with patients. It doesn't matter that they cannot speak our language. You should still be able to teach them how to use the MDI. And it doesn't matter if they cannot speak the English language. You should still be able to instruct them doing a pulmonary function test. Just simply by demonstrating. You do it and have them do it. So you have to know what to do, right? Okay, so chapter 3, I'm moving on. Now we're getting into the drugs. I know your workbooks are due today. Chapter 6 starts on page something. Six starts on page 98. Okay, if you look down at the bottom on page 96, why did I say 98? If you look at the bottom of page 96, let's look at these objectives. You can do that now. Everything that I've done was in preparation for this. It says after reading this chapter, you'll be able to define a sympathomimetic and adrenergic. You should be able to do that now. Right? So I don't have to explain this now. This is what I was saying. This is why we worked on this up to this point. So now that we're getting into the drugs, you understand these fundamental definitions. Who is that? Mr. Love, how are you?
Trick or treat.
Oh, thank you.
Do you have any candy?
No,
I'm wasting my time then, right?
no, you didn't waste your time. Come in and breathe easy.
No, I'm always breathing easy.
All right. How are you? Everybody,
I'm
you
good.
all know this. I kept seeing you all look that way, but I don't know what you're looking at. This is Mr. Jeff Love, our illustrious president of the college.
What's that mean?
That means you're a cool guy.
Oh, okay, okay. Or as they say, aren't you that dude on the website?
How are you this morning?
I'm pretty good.
Good.
I walk down the hall sometimes in person. You're the dude on the website. So, yep. I met all of you at New Student Orientation, right?
Yes.
Okay. So you seem to be doing well, smiling faces, and you've got, well, we have great instructors here, great program directors, but when you look at the example and the definition, you look it up in the dictionary, you see her picture right next to you. Yeah, she does a great
please,
Check
sir?
in the mail.
Yes, it is.
It's payday, you know.
Yeah, yeah.
Guess what?
What?
It is.
It is, isn't it? I hadn't even thought about that.
It is.
Yeah.
And Halloween.
It sure is.
Getting better.
Yeah, it can be. And my sister's birthday.
Yeah.
Yeah, I bought her iPad for her birthday, so she's happy.
Okay, and some of your awareness, you've got orange and black.
Halloween.
So, well, have a great day.
Thank
Hey,
you.
thank you.
I kept seeing you guys, but I didn't see anybody, so I didn't. Okay.
I was
All
at
right.
the point, but-
He was lecturing with you. He was making
Now he'll do that. Okay, so we understand number 1 and 2, right?
Mhm.
Any questions? All right. And then we're going to go over 3 and 4. And then number 5 describe the mode of action for each specific adrenergic agent. So mode of action, is it a alpha drug? Which means what? What is it doing in the body?
Vasoconstriction.
Vasoconstriction. Is it a beta-1 drug? Which is for the
Heart.
Heart.
Okay, and it's 2 effects. Positive inotropic is what?
Increased heart rate.
Inotropic increases myocontractility force. Is it positive chronotropic? That's increased the heart
Heart
rate.
rate.
Both of those make up beta-1 agonists, right? There are some drugs like epinephrine that can do both. But there are some drugs that only do one. Okay? And I don't know how you guys, and I'm not going to hold you to it now, but I don't know how many of you are in the clinical site, I mean in a clinical facility, but there's drugs like dopamine, dobutamine. Those drugs only increase myocontractility force when a person has a decreased cardiac output. Why, as respiratory therapists, would we be concerned about a decrease in cardiac output, even though we know nothing that we can administer is going to improve it? But why are we concerned? Absolutely. Internal respiration. We're concerned about oxygenation, right? Okay. So if a person has a decrease in cardiac output, what type of hypoxemia? Circulatory hypoxemia. That falls into our classifications of hypoxemia, right? So it's nothing we can do from our perspective, but we're concerned about a decrease in cardiac output. So a beta-1 adrenergic drug or a positive inotropic drug will take care of that, like dopamine, dobutamine. Anybody heard of digitalis?
Yeah.
Okay, those are positive inotropic drugs. Got it? All right. And then the positive chronotropic drugs increase heart rate. And then what's beta-2? Bronchodilator. Those are the modes of actions in the sympathomimetics. And a drug like epinephrine does all 3. It has all 3 properties in it. Okay? Any questions? See why I went through what I went through so we don't have to learn this now. You understand this? Yes. All right. All right, then we're going to go through the routes of administration, and we know what we administer is inhalation. So it's either going to be small volume nebulizer, MDI, or DPI. Okay, just that simple. And then we're going to discuss the adverse effects of beta agonists. And then clinically assess, meaning we've given it. Now, how do we know that it's been effective or not? Okay, that's what that means. All right, and then if you look at the top of page 97, adrenergic bronchodilator, alpha receptor stimulation. I'm not going to do asthma paradox. Beta-1 receptor, beta-2 receptor. You know what a bronchospasm is. You know what a catecholamine is. Ooh, and there's those numbers, 3, 5, 8 MP. Ooh, there they are. Right? And then there's GMP. Isn't that something, the president going around asking instructors if they have candy. That's cute.
I think he was serious, too.
I know he was. He was. He was. Like, no, I don't have any candy. I know he's not going to the dental office asking for candy. All right, and sympathomimetic. So most of these terms up here, you understand now, right? And they're all adrenergic, sympathomimetic bronchodilators. So we know these drugs work directly off the sympathetic nervous system. Any questions? All right. Okay, let's look at the key point. It says the adrenergic bronchodilator group is used for the treatment of reversible airway obstruction. Reversible airway obstruction is asthma. Reversible airway obstruction is asthma. Irreversible airway obstruction is what?
COPD.
Now, you see why I keep giving you these terms and I go back and forth. So when you read this again, when it says reversible airway, you know that's asthma. You know asthma is caused by mast cell degranulation, right? You know COPD patients, not all of them, some are CO2 retainers. And you know both asthma and COPD patients initially having a problem exhaling.
Right.
That's what obstructive diseases means. Patient has a problem exhaling. Both conditions are chronic. Once a person is diagnosed with asthma, they have it till the day they die. But it's manageable and it's reversible. COPD is chronic. Once a patient is diagnosed with COPD, they have it till the day they die. But the damage done in the lungs is irreversible. And if the culprit is smoking and they don't stop smoking, it's going to get worse. And you don't know the values, I haven't gone through PFT values because I'm not doing that till next semester. I haven't gone through the PFT values, but you understand COPD is stage 1 and stage 2. Probably not CO2 retainers, right? Stage 3 and 4 probably are. Yes?
Yes.
All right. So our sympathomimetics produce bronchodilation by stimulating the beta-2 receptors on airway smooth muscle. Isn't it wonderful to understand just what that paragraph means? And if I had to explain every little thing, we'd be in this chapter forever and a day. All right, so let's continue on. The general indication for an adrenergic bronchodilator is the relaxation of airway smooth muscle in the presence of reversible airflow obstruction associated with acute and chronic asthma, bronchitis, emphysema, bronchiectasis, and other obstructive airway diseases. What 2 diseases did I tell you make up COPD?
Emphysema
And bronchitis. A patient has to have both of them. They don't get them together. They started out with one or the other. They continue to smoke, and then they develop the other one. So people can have emphysema, never have COPD. Understand? People can have bronchitis, chronic bronchitis. Acute bronchitis is different. People can have chronic bronchitis and never have COPD. But more than likely, if they continue to smoke, whichever one they first started out with, they're going to get the other one. And then together, they will get sicker, go to the doctor. Doctor will send them to a pulmonologist. Respiratory therapist will perform the PFT, pulmonary function test. Pulmonologist will make the call, COPD. That's the only way COPD is diagnosed is by pulmonary function test. Okay? All right. Okay, now we're going to short-acting agents. Short-acting agents are called rescuers or relievers. I'm right at the bottom of page 97 on the left-hand side. They're called rescuers or relievers. That's what they're called. They're short-acting. Short-acting agonists such as albuterol, levalbuterol, perbuterol are indicated for acute reversible airflow obstruction as in asthma. Short-acting agents are termed rescue agents, and we don't care about the year, but the National Asthma Education and Prevention Program. They're also called relievers. See, rescuers and relievers? They're short-acting. They're quick. So what does that say? We don't even know the name of the drugs yet. But if a person comes in an acute exacerbation of asthma, they're wheezing, particularly on expiration. We hear wheezing. They have an increased work of breathing, and we understand that they have an increase in airway resistance. We give them a short-acting bronchodilator. We want it to work right now. We don't want to give them a controller. We want to alleviate their shortness of breath right now. So we give quick-acting, short-acting drugs. And sometimes patients may have a short-acting drug at home, but because they're not compliant, it's not effective. Okay, does that make sense? Yes. All right. Okay. All right. Okay. Indications for long-acting agents. Long-acting agents, we'll go through them, are for the control of bronchospasms and nocturnal. What's nocturnal? Nighttime. Are for control. So if a patient is in distress, I'll just call it distress or increased work of breathing, okay? They need short-acting. Once we get them out of distress and they go home, they still need to be compliant with their long-acting drugs, because their long-acting drugs will keep them from wheezing during the night and keep them from being up and not getting any rest. Okay, so it's very, very important. We can do all that we want to do and it'd be 110% correct. If a patient is non-compliant, it's not going to happen. But it's important for us to be able to educate our patients. Okay? And I don't necessarily know if you would use short-acting, long-acting terms when you talk to a patient, but it's going to be important that we emphasize you have to take this medication even when you don't feel good. Okay? Does that make sense?
Mm-hmm.
All right. Huh?
Even when you do feel good?
Even when you do feel good. On a bright sunny day, it's 98 degrees and you got $1 million in your pocket. Don't forget to take your medicine, because you're going to wheeze if you do, even when you do feel good. Yes. And some patients don't do it, especially children. And they get into trouble. So that's, in general, the difference. Rescuers or relievers, short-acting, long-term or controllers are longer-acting. And longer-acting drugs may last 12, 24 hours. We'll get to them, but they last longer. But long-acting drugs, let me tell you this, long-acting drugs are not effective once a patient goes into distress. They're not effective anymore. Because if the drug works 12 hours and I'm wheezing like a haystack now, am I going to have to wait 3, 4, 5, 6 hours for it to work? I can't afford to. I'll have a respiratory arrest, right? Mm-hmm. I would really probably be hypoventilating and breathing off my peripheral chemoreceptors by then. All right. All right, let's turn to page 98. Let's look down at the bullet on the left-hand side. Ultra short-acting, duration less than 3 hours, is epinephrine and racemic epinephrine. Ultra short-acting, bam, quick. And both have alpha, beta 1, and beta 2. But we as respiratory therapists generally don't administer epinephrine. This drug is generally used for what kind of patient did I tell you? And what else? Cardiac arrest. Cardiac arrest. They've had a full-blown cardiac arrest. Blood is not perfusing. So what's alpha going to do? Cause vasoconstriction and raise the blood pressure. Heart is not functioning. So what is beta-1 going to do? Not only increase the heart rate, but increase the myocontractility force, right? Patient's not breathing, so along with us bagging the patient, resuscitating the patient, they'll get beta-2. So as respiratory therapists, we generally don't administer epinephrine, because if we administered epinephrine for its beta-2 effect, a side effect would be increase in heart rate, and a side effect, it would raise the blood pressure. Does that make sense? Because even though we're only want to administer the drug for that one purpose, it still has alpha and beta-1, and they would be side effects. Does everybody understand that? All right. So when you talk about beta-1 and beta-2, this is why we have these synthetic drugs. There's drugs I had to learn what you will never administer, like isoprel. You won't administer it because we don't use it anymore. It was a very strong beta-2 drug, but it was a very strong beta-1 drug. So the number one side effect when we gave the drug, the heart would pound. So when you, I'm making a point here, when you administer, whether it be generally your small volume nebulizer, before you start the treatment, you want to count the heart rates. During the middle of the treatment, you must count the patient's heart rate. After the treatment, you count the patient's heart rate. Because we're giving the drug for the beta-2 effect, but beta-1 can be a side effect. Got it? How do we know whether our therapy is effective or not? They were wheezing before we started the treatment. We listened to the breath sounds during the treatment. We listened to breath sounds after the treatment. All the wheezing may not be gone, but it should have subsided somewhat. Make sense? We do a pulse before the treatment, or right when we begin. We do a pulse in the middle of the treatment, and we do a pulse after the treatment. And why do we do that? Because we're therapists and we understand beta-1 and beta-2. Now, some of the newer drugs, some of the more man-made drugs, synthetic, I shouldn't say man-made, synthetic drugs have less beta-1, but nevertheless, it's stimulation. So when we administer a beta-2 drug, the potential side effect is tachycardia. All right? And we have to be real careful, because we may have a patient who's wheezing that has a heart rate of 128 when we start. Then you may have to make a decision of what kind of drug you want to give them. And you want to give them a drug that has the minimum beta-1 effect, because you know when you administer your drug, it's going to make their heart rate go up. Does that make sense? All right. Okay, so epinephrine, we generally don't administer. Racemic epinephrine is 50% less potent. It's still alpha, it's still beta-1, it's still beta-2, but it's less potent. Now I'm going to tell you what we use this drug for. We as therapists will administer it, but we generally don't administer it for its beta-2 effect because we have newer synthetic drugs. Racemic epinephrine has that alpha property in it, yes? Sometimes patients come in, I heard just on the news this morning, and Heather, was it your little girl had croup?
Yeah.
All right. I heard it on the news this morning, I thought it was you, that laryngeotracheal bronchitis is referred to as croup in children. And it's on the rise, and it's here in Oakland County. And here, neither here or there, I'm not getting into that, but the reason it's on the rise is because parents have decided not to have their children immunized. And that's a choice. And a lot of them are against immunization because, particularly the little boys, autism, and I'm not going there, but that's the reason. But when children are not immunized, things, or I should say, pathogens or communicable diseases that medicine thought was eradicated, pathogens mutate just like we do. You don't do things you did 5 years ago because you learned that it was ineffective, or if you will, it's just not in you anymore, right? I love jewelry. Jewelry I wore 20 years ago, I don't wear today. Been there, done that. Pathogens do the same thing. So croup is back on the rise, and it's the epidemic portion right here in Wayne County, and they're concerned about it spreading. Children go to preschool, children go to kindergarten, children go to school. Babies come home, when I say babies, 3, 4 years old come home with it, give it to their 6 or 7-year-old, or give it to a high school student, and it spreads. So a child has croup, all right, and it's laryngeal tracheal bronchitis. If they have to be hospitalized, we as respiratory therapists will administer racemic epinephrine. And racemic epinephrine decreases the swelling. It's not anti-inflammatory, but because of the alpha property, it causes vasoconstriction. Now, this won't be the first time, the last time you hear this. When we get into airway management, sometimes patients who have been intubated, that's an endotracheal tube, artificial airway, right? When they've been extubated, their airway is irritated because it's had a tube down there. And you will hear them experience inspiratory stridor. That's an abnormal breath sound. We'll learn about it next semester. What do you recommend to give them? You recommend racemic epinephrine. Why? Vasoconstriction. It's an alpha drug, and it will cause vasoconstriction and reduce the swelling. All right? Now, it's still got alpha, beta 1, and beta 2 properties, right? The beta 2 is not going to bother them. It's fine. But that beta 1 is a side effect. So even when you administer racemic epinephrine for its vasoconstriction properties or its alpha property, we got to monitor the heart rate because we know that drug has beta 1 in it. Everybody understand that? So the greatest potential side effect of our beta 2 agonist that we administer is tachycardia. Yes, ma'am.
So, now what about children that are immunized? Are you saying that the pathogen that causes croup has changed?
It can attack.
So now it can affect even kids that are immunized?
Absolutely, absolutely. There's a prediction. I'm a baby boomer. And we believe for a long time, medicine believed for a long time, once you had the mumps or chicken pox, you were done with it. Oh no, baby boomers are experiencing shingles. It's coming back in a different form. Absolutely, yes.
There's a big outbreak of polio again in Iran and Pakistan, and they're saying that people that are adults are getting it. They saw a lot of kids because nobody could afford food and all the living conditions.
Over there, they don't have the means.
Yeah, they
Over here, we do. We have the means, but some choose not to access, and it's going to affect the children. And we also know that, well, it's not an alarming rate, but scarlet fever is a precursor to multiple sclerosis.
I had scarlet.
Oh yeah, it's a precursor. I know that. My mom died from multiple sclerosis in 1974, so I stay abreast of it. She died young. My mom was 44. My youngest sister doesn't even remember her walking. I do, but my youngest sister doesn't. And she had scarlet fever when she was a baby. Yeah.
My mom did too. She had scarlet fever when she was a baby, and she had it.
Did she? Yeah, yeah. And so, like I said, I'm just teaching you pharmacology. You know, I'm not taking pro or con. I got my grandbaby immunized, but she wasn't a little boy either. But I understand why a lot of people, I know personal families say their son was fine and they got him immunized, and now he's 15, 16, 10 years, 12 years later, and she He basically is autistic. So I understand, but it gives an opportunity for pathogens to mutate. And because they mutate, they then begin to attack dogs. So all the baby boomers, we thought we didn't have to deal, childhood chicken pox is wonderful, but in an adult, chicken pox will kill an adult because it's pneumonia. And then the elderly, as we get older, I know an individual now dealing with shingles. And the first thing I asked her, did you have chicken? Yeah, it came back, but now it's attacked her neurons. So it's coming back. It's coming back, but not coming the same way.
Isn't a lot of times it related to like your stress level and your...
Not shingles.
No? I have a coworker who has it chronically. She's had an allergy for about 2 years now that she hasn't been able to get healed up. But it only she starts getting sores every time she's really stressed out.
Well, it's the etiology behind all that. They need to find out what it is. I'm not a physician, and I don't want to go there, but I got my thoughts on it. She needs to see the right kind of doctor. It can be resolved. Yeah. You had your hand up?
No, so if you've already had like the chickenpox immunization or have had it of your child, they're offering that shingles vaccination now, you should be getting that as well, correct?
It depends. The baby boomers were not, we weren't immunized. We had chickenpox.
See, I had it too, so I'm just wondering, it's like, even if you've had it, should you go ahead and be proactive and use it?
I wouldn't get immunized.
No.
I wouldn't know because I've had the virus. The virus is in my body already.
They're saying that you should be, after 55 to get the shingles shot. Even if you had chicken spot.
See that? Yeah, that's what I'm saying.
But it's saying after 55, not before, because some people,
Right.
once they heard shingles, they were 35 years old and trying to get the shot. And
Right.
It's not going to do any good.
I wouldn't do it. I wouldn't do it. But it's my choice. It's my choice. I'm not going to do it because I have asthma. And anything they inject in me probably will make me wheeze. That makes sense? Mm-hmm. All right. So whooping cough is back on the rise. My whole point for that was sometimes they may administer racemic epinephrine to decrease the swelling. But in this case, the racemic epinephrine is not an anti-inflammatory drug. They're administering it for its alpha properties. Someone who has been intubated, now extubated, and they complain of a sore throat. They may call you in, if a doctor call you in or whatever, what do you recommend? You want to recommend the administration of racemic epinephrine. You don't want to give them epi because their heart rate, they will probably just get up and run away. That's too potent. So we want to administer racemic epinephrine, okay? But we have to check the pulse before, during, and after, because we know that drug includes a beta-1 effect, right? All right, so they're short-acting. They work quick. The best drug, some people said, some of you mentioned people carry an EpiPen to prevent anaphylactic shock if they're allergic to bee or wasp or whatever, and that's true. But generally in the clinical environment, as respiratory therapists, we don't administer, I've never administered epinephrine, because it's so potent. But they do use it for the cardiac arrest because it has all three properties. So if you have a question where a child has croup, or if there's irritation of the airway after following extubation, meaning the tube has been removed, what do you recommend? You're going to recommend racemic epinephrine, and you're going to recommend it because of its alpha effect. In this case, it's not a beta-1 or beta-2 agonist, it's a alpha agonist. But we know side effect will be beta-1. Make sense? Yeah. All right.
Are there any anticholinergic drugs that are specifically negative inotropic or negative chronotropic?
Atropine.
Atropine.
Yeah. Atropine is negative chronotropic.
Okay.
Mm-hmm. We don't, if a person comes in ER, full-blown cardiac arrest, they're going to administer epinephrine. The epi got the heart rate going somewhere between, I think some numbers, 30 and 35. They don't want to give any more epi. They'll administer atropine. So the indication for atropine is bradycardia. The indication for asystole is epinephrine.
Okay.
Yep. You'll
So
learn that
maybe-
as a second year
So it's
student.
almost like a synergistic effect. Okay.
Yeah.
So that's a break then, that slows the heart down immediately, that just controls it.
No, it won't slow it down, it'll raise it up. If a full-blown cardiac arrest, they'll give epinephrine. If the patient is bradycardic, they'll give atropine. Don't worry about that now, I'm just answering her question. You don't have to know that now, we'll go for that in a second.
But I really wanted to get confused.
I think you are already.
I think you're right.
Okay, short acting, duration 4 to 6 hours. Now this is what you'll be administering. Albuterol, levoalbuterol, metoprolol, and perbuterol. And let's go look at the short-acting bronchodilators up in the table 6.1. Metoprolol is Alupent, and it comes in small volume nebulizer. See it?
Yep.
And you see what's its receptor preference? Beta 2. What's the side effect of it? Potential increase in heart rate, tachycardia. All right. Below that is albuterol. How many companies produce it? 1, 2, 3, 4, 5. 5 companies produce it. It's still albuterol, official name, generic name. But one company calls it Proventil, another company calls it Ventolin, another company calls it ProAir, another company calls it Acunel, and another company calls it Vospiral. ER, extended release. Vo, you have any idea what that Vo is? I closed the door, the heat is running, it's dusty, it makes my nose run. I need an alpha drug. What is Vo? Volume. Inspire, what does spire mean? To breathe. Vospiral. So all 5 companies make albuterol, but each company has to have its specific trade name. See it?
Mhm.
All right, 4 to 6 hours. All right, next is perbuterol, that's Maxair. And Maxair only comes in an MDI. So in ER or on the floor, you won't be using this drug. It only comes in MDI. Patient may come from home using perbuterol, but you won't administer it because it only comes in MDI. What you will potentially administer is the metoprolol, because it comes in small volume nebulizer, and you could potentially, definitely administer the albuterol. See the small volume nebulizer? Okay. So patients may be at home on it, but they will be home probably on the MDI or the DPI. And when they come in the hospital, you will administer the small volume nebulizer. Okay? So some of these drugs, like perbuterol, you'll never administer, but you need to be familiar with it, so if your patient comes in the hospital, you'll understand what they're on at home. And then if a patient says, well, why are you giving me this? This is not what I take at home. You should be able to explain to them, you take this at home in this form, and this is really like the same thing, but I'm giving it to you in a different form. Okay? And the more you do it, like I said, when in respiratory care, you'll understand respiratory care, but may never be able to spell your name backwards. All you got to do is have a patient, and maybe you give Q1 hour, Q2, or you're in the clinical environment and you give them 3 or 4 treatments a day, and you're there for 3 days or 2 days. You got it. You do it, because that's part of what you do. Okay, and some patients will ask questions, and don't be intimidated by it. Next is levoalbuterol. Albuterol came first, and albuterol was produced in Canada and Great Britain, the United Kingdom, in the 70s. My grandparents lived in Canada, and my grandmother gave me MDIs all the time, and I couldn't get it here. She was using albuterol, late 70s, early 80s. It was a wonder drug. It's synthetic. It doesn't have the alpha property in it. It doesn't have all that beta 1 property in it, like epinephrine and racemic epinephrine. It's synthetic. But nevertheless, because it stimulates the sympathetic nervous system, increasing the heart rate is minimal, but we still have to monitor the pulse before, during, and after any beta-2 drug you administer. Does everybody understand that?
Yes.
Okay. So not only will you be instructing the patient how to use the treatment or take the treatment, not only will you be listening to breath sounds, that's called auscultation, before, during, and after the treatment, you want to do pulse. And you're going to record it. And we understand as therapists, we're administering our drugs for the beta-2 effect, yes? Side effect is beta-1. Any questions? So that's why I gave you the sheet. Now you just got to start learning trade and generic names. I know you're working on your drug cards, but we're just going to be a little bit more specific. Okay, levalbuterol, Xopenex, comes in a small volume nebulizer, and Xopenex HFA, and I will explain that, comes in an MDI. So albuterol was manufactured first, and then they changed it a little bit, because I was on albuterol even before my doctor gave it to me. My grandma was giving it to me in the 80s. And I took it for about 25, 27 years, if I needed it. Long time. And now it doesn't work, so I use Xopenex if I need it. Okay, so those last a little longer. And then your long-acting duration is salmeterol, formoterol, and aformoterol. These are the ones the patients will go home on. And if you look at the long-acting beta-adrenergic bronchodilators, you notice the majority of them come in, two come in DPI. You probably will not use these in a clinical environment. What you're going to use are the rescue drugs. The Xopenex, the Alupent, that's what you're going to use. Okay? So you have very short acting, which is your epi, and as a respiratory therapist, you probably won't do it. Now, I don't know. It's a different world for babies. So next year, in fact, I have to ask Ms. Polk if they use it. I doubt if they do, but I don't know about the neonates. Everything that I teach you, unless I specifically say, is for adults. Neonates is another world, pediatrics is another world, and I don't step into those worlds. All right, so everything that we go over is for adults. So what you need to know that all of these drugs, the first two classifications, ultra short acting and short acting, are your rescue drugs, your reliever drugs. Your long-acting adrenergic beta agonists are your controllers. And what I want you to know about these, in addition to trade name and generic name, if it says ultra short acting, the duration is less than 3 hours. If it says short acting, the duration is 4 to 6 hours. And if it's long acting, it'll last up to 12 hours. Okay? I don't want you to pull it out, but a couple of weeks ago I gave you a handout, and it was over drugs, and it was a man, I think he was COPD, and he came in, and the doctor had written an order for him to take albuterol, because he wasn't wheezing, BID. And we couldn't go over it because we hadn't gotten this far. Now, if you look at albuterol, what classification? We know it's beta-2 agonist, but is it ultra short-acting, or long?
Short-acting.
It's short-acting, right? So it's 4 to 6 hours. The doctor had written an order for this man to have the treatment BID, which is what? Twice a day. Why was he wheezing within 3 to 4 hours? because he needs the drug more than twice a day. Okay? So if you have a patient who's wheezing, and when the doctor assesses the patient and they're not wheezing, oh, they only need the treatment twice a day, you have to let them know this patient is wheezing every 3 or 4 hours. They don't need this drug. They can't take this drug twice a day. This is a short-acting drug. It should be administered within 4 to 6 hours. And I want to give it Q4 hours until he comes out of this wheezing exacerbation. Make sense? That's how you have to talk to doctors. Because they may say, well, why do you want to do that? Be able to tell them. I'm administering a beta-2 agonist, and the drug that you order is short-acting. It only lasts 4 to 6 hours, and you're saying and giving them one twice a day. That's every 12 hours. The man wasn't going to make it. Does that make sense? Yes. So with these drugs, it's important to know how long it'll last. So it's not uncommon for your short-acting drugs. You may have to give Q4 hours. You may have to give Q5 or Q6 hours. And sometimes doctor will say, well, how do you want me to write the order? And I'll say Q6 hours and PRN. So if I give it every 6 hours, but in the next 3 or 4 hours, if my patient is still wheezing, I can still give it again. Make sense? Mm-hmm. You have to learn how to use common sense based on what's going on with your patient. All right. And we're learning out of the book, but there is no book a man can write that will address every patient scenario and assessment. It's common sense. Right? Don't come to where the book says, I don't care. What is your patient exhibiting? That's where you would make a decision on what to do. I don't care what a book says. It's based on patient assessment. Got it? Every time you give a beta-2 agonist, you're going to listen to breath sounds before, during, and after. You're going to assess pulse before, during, and after. Got it? Potential side effect of beta-2 agonists are beta-1, or if you will, tachycardia. All right. We're not going to go through the chemicals because this is not a chemistry class, but I want to go through nope, not going through all that. Not going through all that. I don't care about chemical drugs. Okay. Turn to page 104. And here is albuterol. An extended release. So when you see ER, that's extended release. You may see XR, that's extended release, meaning that it's a long-acting drug. Patient could go home on it. It's a controller drug. All right? So ER is extended release. XR is extended release. And it's one more. SR, slow release. They all mean the same thing. And what it means is the person takes the drug, but it's only so much released. The body, the medication is only released at certain intervals. Now you know that's man-made, right? But it's okay. It's only released during certain intervals, and therefore the drug can last longer. Okay. So now let's talk about it. We talk about catecholamines. They're naturally occurring hormones in our body, right? Norepinephrine and epinephrine. Norepinephrine is alpha, raises the blood pressure. That's the sympathetic nervous system. It's quick, then it stops, right? Because it's the sympathetic nervous system, and we operate off our parasympathetic nervous system, yes?
Right.
All right. Then we've got these those are the ultra short acting. Then we got these short acting, 4 to 6 hours. They're not naturally occurring of catecholamines, but they act like epinephrine or norepinephrine relievers, rescuers. Do it and stop. But these long-acting drugs are not naturally occurring. They don't act like natural occurring catecholamines because they're beta-2 agonists, But generally, if we had stimulation of the alpha, beta 1, or beta 2, it would be quick. These drugs last a long time in the body if the patient takes it correctly. Okay, so they're not naturally occurring catecholamines. So all of this stuff in here, we're not going through because we don't have to know all this. Okay? Let's turn to page 106. I just wanted to tell you about extended release albuterol. If you go through here, bronchodilator effect, when you see that term, what does that mean to you? Beta 2 agonist, and what is it doing in the airway?
Opening it up.
Opening it up. That's all you need to know. Okay, open it up. All right. Let's look at I'm not going to go through that. Nope, not going through that. Do I care? Nope, nope, nope. All right, let's go turn to page 107. So you make sure you learn the trade names and the generic names on page 98. You know the classifications, ultra short-acting, long-acting. That's what I want you to know. Page 98 is right in front of you, okay? Any questions? All right. Let's turn to page 107. All right. What I'm going to do is introduce you to a new classification of drugs, but it is not a beta-2 agonist. It's not sympathomimetic, but it's right here because it's dealing with asthma. Anti-inflammatory agents. Anti-inflammatory agents. That means what? Reduces swelling, yes? It is a classification of drugs. It doesn't work on the parasympathetic nervous system. It doesn't work with the sympathetic nervous system. But if it's in here with the bronchodilators, how should we call the drug? Synergistic. Very good. It's synergistic. Okay, look on page 107. All right. You learned it's 3 causes to wheezing, right? One cause is what? Mast cell degranulation. What's another cause? Excessive secretions. And the third cause? Inflammation. Ah. Now, on page 107, I'm talking about a new classification of drugs, and they're called anti-inflammatory drugs. So what would they do? Reduce swelling. Okay? And they're synergistic. Everybody with me? Okay. Okay, look on page 107, and it says, because of the ongoing concerns of safety of long-acting beta-2 agonists. Everybody see that?
Mm-hmm.
The FDA, Food Drug Administration, is now requiring changes on how long beta-2 agonists are used in the treatment of asthma. So, and I'm not concerned about the date, but just in 2010, the FDA is now saying long beta-2 agonists, now you know what a long beta-2 agonist is, right? Mm-hmm. All right. Are not to be used without a controller medication, a corticosteroid. Corticosteroid is an anti-inflammatory drug. So asthmatic patients can be on beta-2 agonist and corticosteroids at the same time. The beta-2 agonist is doing what? Treating
The dilation.
treating the what?
Bronchoconstriction.
The bronchoconstriction. The corticosteroid is treating the what?
The inflammation.
The inflammation. You got it. Because remember, I told you it's 3 causes why people wheeze. And sometimes asthmatic, I've used the term loosely. I'm still not holding you to it. Staticus asthmaticus, right? Staticus asthmaticus is a classification of an asthmatic patient. They've had it for a while, and they no longer respond to conventional beta-2 agonists. So staticus asthmaticus is the type of patient that perhaps would need the anti-inflammatory drug or corticosteroid synergistically, because just giving them a beta-2 drug is not enough anymore. Okay? So right there, that first bullet, you can write staticus asthmaticus. Staticus, do I need to spell it?
Sure.
Sure.
Thank you.
Why not?
Thank you.
Statitis. Statitis. It's actually staticus. Asthmatic. These kind of patients indeed have asthma. They've had it for a while, and they no longer respond to conventional beta-2 drugs. So we got to give them something else, right? But we know as a therapist what causes wheezing. We know as therapists what causes bronchospasms. We know the beta-2 agonist is working on the mast cell degranulation. But their airways can be greatly irritated and swollen. So the corticosteroids will reduce the inflammation. And so corticosteroids are synergistic to beta-2 agonist for a staticus asthmaticus patient. Somebody in here said, I don't know if it was them or their child, had to take a beta-2 agonist, and was that your?
They put her on corticosteroids, like a syrup.
Yeah, well, because she's a baby. She's not 5 yet, right?
Yeah, she's 4.
Yeah, she's a baby, that's why. Yeah. If she had been an adult, we probably could have administered via inhalation.
Okay.
Okay, so her baby had swelling, and they gave her a liquid to reduce the inflammation. Okay? All right, so you got a new classification, corticosteroids. What do corticosteroids do? Reduce inflammation. And why do we need reduction of inflammation? Because we know it's 3 causes to wheezing. Does that make sense? Any questions with that? All right. Okay. The second bullet says, long beta-2 agonists should not be used by patients who are on controlled low-dose or medium-dose inhaled corticosteroids. So we can give inhaled corticosteroids, but what the FDA is now saying that if they're on low doses or medium doses, they really shouldn't be using the controllers. Use either or. And I can't tell you one is better than the other. It's just going to be based on the patient, whether they need a long-acting beta-2 agonist or whether they need a corticosteroid. It's all going to be based on patient assessment.
Like my son used to be QR.
Is he?
Yeah.
Yeah. That's what he needs. That's what he needs. Now, I'm just throwing it in here. I'm not expecting you to know this. How do we know whether our medication is effective or not? Well, when we administer one treatment, we're going to do breath sounds before, during, and after. We're going to ask the patient how they feel. They can respond. But let's say we want to know, or the pulmonologist or whomever wants to know if this medication is effective. They may have the patient take the medication 6 weeks to 8 weeks. Call them back into the pulmonary function lab and do another pulmonary function test. If the pulmonary function test results improve by 20%, the drug is effective. If it doesn't, they need to change the strategy. That's how we know if drugs are effective or not. Okay? So just to make sense for you, we're talking about an asthmatic. Does an asthmatic have a problem inhaling or exhaling?
Exhale.
Okay. So if they have a problem exhaling, they're really short of breath, and their values to exhale when we look on the PFT is going to really be decreased. Doctor will put them on this drug and say, I want you to come back, and we'll tell them, I need you to make another appointment now for 2 months from now. Okay? They come back, well, I don't feel my best, but it's okay, because they're getting some relief. we have them do that same PFT again, and if those values are baseline that we got 2 months ago, if those values have improved by 20%, we know that drug is effective and the physician will leave the patient right there. If those values have not improved by 20%, we need to recommend something else for the patient. That's how we know if drugs are effective for asthmatics, beyond them telling us, yes, I feel better, no, I don't feel better. Okay?
Would you expect an improvement even more after, like, let's say that came back 20% improved, like, let's say 2 more months later? Would it be even more effective? Or
Not necessarily. It's just maintaining.
Okay.
Drugs just maintain. Drugs just maintain. Does that make sense what I'm saying? Yes. So pharmacology and pulmonary function testing go hand in hand when you talk about asthmatics and COPD patients. I know you haven't learned it yet, but you have to. That's another way to assess whether drugs are effective. Okay, so now let's talk about the COPD patient. It don't matter, and when I say this, I'm not painting a dismal picture. It don't matter what we put them on, because they have irreversible damage. So all the drug is do is maintaining. But I can look at a PFT and see if they've gotten worse, and that's what a pulmonologist would do, say, they've gone from mild obstructive disease to moderate obstructive diseases. So they've changed categories. They've moved from a stage 1 to a stage 2. Does that make sense? And then we do another PFT in 3 years from now. They've gone from moderately to severely. And we look at the blood gas and they're retaining CO2. And then the doctor will then diagnose them as CO2 retainers or COPD. And then stage 4 is terminal. Make sense? Mm-hmm. It's all done by PFT results.
So what to clarify, you're saying that an asthmatic patient, their expectation is that once they're on medication, they should improve at least 20%. But with a COPD patient, all they're going to do is maintain it.
Yeah.
They're not going to ever.
They don't necessarily improve, or if they improve, we're not looking for it to be 20%.
Okay.
Yeah.
The best you can hope for is generally
maintenance.
Okay.
Maintenance.
Thank you.
Right. And we're not even going to look for 1% improvement if they're smoking. And they'll lie and tell us that they're not smoking, but if we get a carboxyhemoglobin level, that'll tell us. It should be less than 1%, and it comes back 8%. Either the co-oximeter is not telling the truth, or the patient. You choose. And I'm not saying that to be judgmental. You just, yeah, right. So if that's the case, we don't expect to see improvement in the PFT. Does that make sense?
Mm-hmm. Yes.
I'm trying to tie stuff in for you. So with pharmacology, particularly the asthmatic patient and the COPD patient, pulmonary function testing is very important. Very, very, very important. Because it will tell us the severity of the condition. Is the medication effective or not? So yeah, we do go by what the patient tells us and how they feel, but we want to see lung function. We want to know how well they can exhale. And we do that by getting a PFT. And it'll tell us how well they exhale in 1 second, how well they exhale in 2 seconds, how well they exhale in 3 seconds. Bam, we got the values. That speaks volumes to whether this medication is being effective or not. All right?
Yes.
Okay. The third, it says, long-acting beta-2 agonists should only be used if patients are not controlled with agents such as inhaled corticosteroids. So what is this saying? For asthmatics, try the corticosteroids first. And if the corticosteroids are not effective, then let's put them on a long-acting beta-2 agonist. Does that make sense? Mm-hmm. It's saying, give them the corticosteroid, but give them the short-acting drugs first. That's what this is saying. What is your son, can I ask you, what's your son's diagnosis?
Asthma.
Ah, there you go. And what else is he taking with the QVAR?
Just QVAR.
Just QVAR?
Yeah.
Okay.
When he has symptoms, he takes albuterol.
When he has the symptoms.
Yeah.
Okay, very good. So in other words, he's taking QVAR to maintain or to minimize or to have no anti-inflammatory condition in his airways. Everybody understand? This is exactly what I'm saying. When his asthma does flare up, what does he take? Albuterol. He takes short-acting drug to relieve it. And that's him. Somebody else, that may not be the case. Okay, and who made that determination? Who figured that out? Pulmonologist. Thank you. Pulmonologist figured it out.
And the PFT you're talking about is the one that they have to blow in the deep breath and they measure their breath. That's what PFTs are, because that's what he does.
That's called a
when he-
spirograph.
Yes,
Peak flow.
spirograph, because they do it with his normal breath and then he goes, they give him that
Suck in
big
real
draw.
deep
Yeah.
and blow it out
Blow
fast and hard. Blow, 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 blow.
Yeah.
When he's blow, 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 blowing, his FEV 1, 2, 3 are being measured.
Yeah, that one.
How much he exhaled in 1 second, how much he exhaled in 2 seconds, how much he exhaled in 3 seconds. And in obstructive diseases such as asthma or emphysema, those values are markedly decreased because they have a problem exhaling. Make sense? All right. Yes, ma'am.
What is the PFT machine that encloses? It's like a circular device?
Body box. That's
Okay.
not a body box, but it's called plethysmography.
Okay.
Yeah.
Does
All
my daughter
places
have-
don't have it,
Okay.
but some do.
And my daughter ended up doing that because we thought she was asthmatic.
Yeah, some places have it, not all places, but you can still do it. Simple spirometry is just called a spirogram. Spire means to breathe. All right. And the body box does it all. All right. Okay, so let's go back to long beta 2. I'm back at the first bullet. Long beta 2 agonists are not to be used with a controlling medication. So that's saying you can use an anti-inflammatory drug, but it has to be with the short-acting, like albuterol. That's what it's saying. Why do you think the asthma, or whoever it is, recommended, the FDA recommended, why do you think we shouldn't be using long beta-2 agonists and corticosteroids together?
Tolerance?
Tolerance and what else?
Overstimulate.
Overstimulate? Good. Keep talking. Keep talking. What probably wouldn't happen at night? They wouldn't sleep.
Sleep.
They probably wouldn't sleep because the stimulation of the sympathetic nervous system. Then look at this. If the patient was taking both, how will we know which one is effective? We wouldn't know which one is effective. So the text is saying, the FDA is saying use one or the other. Now, if your patient, such as her son, is on QVAR, which is an anti-inflammatory drug, he only takes the short-acting rescue drug when he needs it. So what is that saying? His pulmonologist, his mom, knows that the anti-inflammatory drug is maintaining his asthma, maintaining him from wheezing. What causes wheezing? Inflammation, in his case. Does that make sense?
Yes.
All right. All right. The second bullet says beta-2 agonists should not be used by people who are on a low dose or medium dose inhaled corticosteroid, such as her son. And the third bullet says long beta-2 agonists should only be used in patients who are not controlled with agents as an inhaled corticosteroids. I'm on the fourth. Beta-2 agonists should be used for short-term use only, and that's what she said. Her son is on QVAR, which is a corticosteroid, but he will take his short-acting if he needs it. And his mom and the pulmonologist have taught him when he's wheezing what he needs to do. Yes?
Okay, so the first bullet says the long-acting beta-2 agonists are not to be used without a controlling medication.
Right.
But the rest of them say it's not good to use, you shouldn't use them together.
Yeah, controlling medication in this case is not, this controlling medication is an anti-inflammatory drug.
So it's, okay, because it said, all right. It just
You
seemed like- yeah, it just seemed like it was saying the opposite of what the rest of the bullets.
No, what this is saying, bullet 1 is saying, long beta-2 agonists should not be used without a controlling medication. So it's saying, like with a corticosteroid, it should not be used without a controlling medication. But then the next bullet is saying long beta-2 agonists should not be used by patients who are controlled on a low dose or medium dose inhaled corticosteroid. It's given specifics. It's given specifics, and this really would be for a pulmonologist or us. All right. I'm back on the third. Long beta-2 agonists should not be used only if patients, should be used only if patients are not controlled with agents such as an inhaled corticosteroid. Fourth bullet, long beta-2 agonists should be used for short-term use only. Once asthma is controlled, the long beta-2 agonist should be discontinued. Or if we can control it another way using corticosteroids, that's how we control it. Okay, why don't we want patients to stay on long beta-2 agonist drugs? Tolerance and its stimulation of the sympathetic nervous system, which is not homeostatic. Make sense? All right. All right. Yeah, they could be bouncing all over the place, crazy, right? Probably running backwards and barking at the moon. Children should use a long beta-2 agonist only in conjunction with a corticosteroid. The use combination product is to increase adherence or certainly synergistic. So here's this control. I'm not expecting you to remember this, but what I do want you to understand that anti-inflammatory is a new classification of drugs that we just learned here because we understand the three-way wheezing occurs, a bronchoconstriction occurs, right? We can give a corticosteroid, or the patient can be on corticosteroids. We can administer it via inhalation. We haven't gotten to that chapter. But we can administer it via inhalation, but they shouldn't be on a long-acting beta-2 drug for too long. Just give it to them till the asthma is controlled and move them out of the long-acting beta-2 drug and find something else to give them. And finding something else is probably the anti-inflammatory drugs. And finding something else, if they do have allergies, educate them, and that may not be us, that may be an allergist. Educate them on what they should eat and what they shouldn't eat, or if they have exercise or cold weather-induced asthma. When it's 10 below, you need to cover your mouth up. Okay? So a lot of this, particularly with asthma and emphysema, is education. They can't be on both for a long time. So let's put them on an anti-inflammatory drug, and let's get away from this long beta-2 acting drug. That's why I said you probably won't administer these in the hospital. Okay, you will not. But nevertheless, you need to know what they are. So what do I want you to know? Go back to page 98, table 6-1. That's what I want you to know, okay? Any questions? Turn back to 107. We've gone through this. Look for beta receptor and alpha receptor activation. Look over here. You see 3,5-AMP. You know what that is now? That causes bronchodilation. I wasn't making it up. There it is. I just made it simple for you. So it doesn't matter who's writing or what they say. If you see an increase in 3,5-AMP, you know that is an adrenergic drug. You know that is a sympathomimetic drug. And particularly if it's beta-2, it's causing bronchodilation. If it's beta-1 chronotropic, it's increasing the heart rate. If it's beta-1 inotropic, it is increasing the myocontractility force, right? And if it's alpha, it's doing what? Causing vasoconstriction and raising the blood pressure. Any questions with that? All right. Turn to page 110, and I'm going to stop. Inhalation route. Inhalation route is generally MDI, small volume nebulizer, or DPI. I said that. That's what it's saying. Why do we administer inhalation? Onset is rapid. Smaller doses are needed compared to with oral doses. And then oral dose would take longer to get in our body, wouldn't it? All right. Side effects such as tremor and tachycardia are reduced. Where did that tachycardia come from? Beta 1.
Beta 1.
Beta 1. That's a side effect. We're giving a drug for beta 2, but beta 1 nevertheless is there. All right. Drug is delivered directly to the target organ. Breathe in, breathe easy. Let's take care of it. And then inhalation is painless and safe. That's why we do it. Number one disadvantage. What do you think is the number one disadvantage?
Not all of it gets in the lungs.
Not all of it gets in the lungs, but even before that.
Patient error.
If the patient can't follow instructions. That's the disadvantage. If the patient can't follow instructions, such as Heather's 4-year-old. And how old is your son, Lori?
Mine is 11.
Oh, 11, okay. Well, he should be able to, he doesn't want to follow instructions, right? Okay. Or you have someone dealing with dementia or something. They just can't follow instructions. That's a disadvantage. Does that make sense? All right. All right. Continuous nebulization. Sometime you may, now this is in children. I'm stepping into the children's world. Continuous nebulization. Sometime with children, we don't want to keep giving them these treatments every 2-3 hours. So what we'll do is use a large volume nebulizer, and we'll use a certain dosage and put it in the nebulizer and give them continuous nebulization. Now they won't have a mouthpiece. They'll have the nebulizer, corrugated tubing, and an aerosol mask. And every time they take in a breath, they're going to inhale some of the medication. Now this is someone when we call it sibilant wheezing. What happens in children, and I learned this from an allergist. I didn't know this. What happens in children, sometimes their little chest gets so tight, you don't hear the wheezing. You do not hear the wheezing. And that's what happened to Paulette when she was 3 years old. I kept listening to her breath sounds. I didn't hear any wheezing, and I thought she was okay.
Same with my son too. I never heard him.
You never hear him wheeze. That's called sibilant wheezing.
So how do you figure it out?
Well, pediatric respiratory therapists and pediatric physicians and nurses, I assume, know. Like I said, it's a different world. But what they'll do, you don't want to keep imposing, giving them a treatment. Well, there is a disadvantage to that mask, but they will give it continuously. And continuously can be for the next 8 hours, next 16 hours, until that wheezing breaks. Now, once in a while, we do it with adults. But most of the time, continuous nebulization is something they'll do in ER. And they'll do it in ER to keep from intubating the baby or the child and put them on a ventilator. Okay? And once you see it, you'll understand. I hope to God you never see it, but unfortunately you are. All right, so that's the only difference between what we do, administer the treatment, and continuous nebulization. All right, it says continuous nebulization may be simplified by frequent treatments, or if not, we can continue to give it based on the child's weight, and they will every breath they take, they will inhale some bronchodilation. And you know what's good? Now, this may sound weird. We don't hear any wheezing, but they know that the patient, the baby is, or child, 11 years old, whomever, is in distress. When that medication becomes effective, then we'll hear wheezing.
How ironic.
Isn't that ironic?
Yeah.
And we know they're getting better. So we won't hear any wheezing. Bad. We give them the continuous aerosol. We begin to hear wheezing. Good. And we continue to give them, and then that wheezing that we do hear, it will begin to subside. Does that make sense? Mm-hmm. Is that crazy or what? But that's it. That's what happened. Okay, so we've gone through the bronchodilators, and I went quick because I didn't have to talk about beta 1 and beta 2 and all that. Learn them. That's what I want you to do. Learn trade names and generic name, ultra short-acting, and long-acting. And what you should know is why we don't want to keep patients on long-acting beta 2 agonists for over a period of time. Remember, it's still part of the sympathetic nervous system. All right? All right, any questions? Okay, I'd like for you to put your workbooks back over there on top. You can leave your